Good morning, everybody. Welcome back. I'm so happy to meet you again in this very important project, rule of whole body ultrasound in shock management. Let us see this case. A 53-year-old male patient smoker, known case of ischemic heart disease, for BCI next week. When I saw the patient, he was planning to do BCI in the next week. Presented to our clinic because of 24 hours abdominal pain, Bouchard dizziness, dyspnea, no cough, sputum, or hemoptysis. Patient noticed that he has a constipation since this abdominal pain, but he can pass flatus. Patient, despite has been on diuretics, furosemide, spironolactone, and the other anti-ischemic drugs, bisoprolol, ramipril, and aspirin, but he noticed he is passing very little urine. So, 24 hours abdominal pain, severe abdominal pain, and the patient complain of Bouchard dizziness, dyspnea, oliguria, constipation. On examination, patient is fully conscious, oriented with low-grade fever, 37.6, blood pressure supine 105/65, drop to 90, 55 on standing, there is Bouchard drop, heart rate 80 per minute, chest examination bilateral basal crackle, heart gallop, abdomen distended, tender all over, more on the right hypochondria with shifting dullness. O2 saturation of room air 93% with respiratory rate 25 per minute. Okay. Patient is complaining really of, we started whole body ultrasound for this patient who complain of several organ dysfunction. He has dyspnea, hypotension, abdominal pain, several oliguria, four major organ dysfunctions. Really, with clinical examination and the history, you can collect a very important information, but you need to complement this information by whole body ultrasound in your clinic, in your emergency room, in your ICU. We started, as all of you know now, in any patient with signs of shock, we need to start by inferior vena cava to know what's going on. Inferior vena cava is elephant. Inferior vena cava is too much dilated and non-collapsing, approaching 3 centimeter. Definite there is cardiogenic or obstructive element here. So in this situation, you should go immediately to the heart to know what's going on. In our patients, this is a 4-chamber view. Generalized hypokinesia with this kinetic septum, and as you see here by visual assessment, the anterior left mitral valve is far away from the septum during diastole, and no proper thickening and dyskinesia. This denoting in our patients is denoting severe left ventricular dysfunctions by visual assessment. In this type of patient with dilated non-collapsing inferior vena cava, really from the advanced critical care point of view, you need in this type of left ventricle and this acute event in the patient with dyspnea and shock, you need to go to assess 2 important things with this bad left ventricle. You need to assess the left atrial pressure by just putting the pulsed wave Doppler at the tip of mitral valve and look for the mitral valve flow in diastole here. This is the E wave, which is too much increased in velocity with very rapid descent, very rapid deceleration time, and very small A wave. This E to A ratio is more than 2. It's 3.5. This means that in our patient with severe left ventricular dysfunction and this restrictive grade 3 diastolic dysfunction by mitral valve flow, that means our patient has increased left atrial pressure. So this is the physiology, and this is very important in our patient. By the anatomy, there is severe left ventricular dysfunction by the anatomy, but by physiology, there is increased left atrial pressure. What else? You will put the pulse wave Doppler here at the LVOT, and will measure the LVOT VTI here. As you see here, there is a closing click of aortic valve, so I am in the proper position. The LVOT VTI is 8.1 centimeter, that it's far less than normal, which is 18 to 22. That means our patient has very low stroke volume, because LVOT VTI is a surrogate of stroke volume. So very low stroke volume by very low LVOT VTI and very high LVOT left atrial pressure. That means it's going with the cardiogenic element definite with dilated non-collapsing inferior vena cava. And you should consider here very important point. Really, there is very important point here also. With this type of severe left ventricular dysfunction and very bad stroke volume, I will expect the heart rate to increase to compensate and increase cardiac output. But unfortunately, our patient has been on beta blocker. You should consider this in diagnosing your patient. Beta blocker decreasing the heart rate, so increasing the shock state, increasing the shock state by decreasing the heart rate, because cardiac output equal stroke volume for heart rate. Stroke volume is very low here, and also heart rate is low for the patient, so this worsens the state of shock. So I have here the bradycardia as drug induced and severe left ventricular dysfunction as a cause of this severe low stroke volume and low cardiac output state. So what about dyspnea and hypoxia in our patient? You have now severe left ventricular dysfunction. You have restrictive diastolic dysfunction, restrictive pattern diastolic dysfunction grade 3 with increased left atrial pressure. You have very low stroke volume, and when you saw the lung here in our patient, there is clean pleura with B-line and right pleural effusion. It's going with cardiogenic pulmonary congestion. So in just a couple of views, you can now sum up. There is markedly congested inferior vena cava, severe left ventricular dysfunction with wall motion abnormality, grade 3 restrictive diastolic dysfunction with increased left atrial pressure, very small LVOT VTI denoting very low stroke volume, bradycardia by beta blocker, B-lines with clean pleura and right pleural effusion. Considering low pressure in our patient, low urine output, so it's the complete picture of cardiogenic shock with cardiogenic pulmonary edema. It's very clear. By this very important target view, you target the lung, you target the inferior vena cava, you target the heart by advanced critical care ultrasound. In a couple of views, you know, you reach it to a complete view. You have the bad left ventricle and the high left atrial pressure and the P-line in the lung. That this, no doubt, this is very important in diagnosing the cardiogenic shock and the cardiogenic pulmonary edema. But you should ask yourself, why all this happened 24 hours after severe abdominal pain? So it must be a precipitant in the abdomen. Our patient has a grade of heart failure because he is non-ischemic heart, severe ischemic heart disease. But why all this happened over 24 hours after abdominal pain? So it should be a precipitant here. It should be an acute on top of chronic element. So it must be a precipitant in the abdomen, most probably in the abdomen. Clinically we saw marked abdominal distension, tenderness, rebound tenderness, and shift in dullness. This could be anything in our patient. In our patient, what's the differential diagnosis of this diffuse abdominal distension and the pain and tenderness, rebound tenderness, shifting dullness? Could be anything. Our patient has left side heart failure, so it could be a cardiac cirrhosis with ascites, and now over these 24 hours, patient developed spontaneous bacterial peritonitis of his cardiac cirrhosis and developed this all picture and this very good explanation, and will explain everything. It could be acute cholecystitis because the pain really and the tenderness is concentrated on the right hypochondria. It could be acute mesenteric ischemia. Our patient is dilated cardiomyopathy, and it's very easy to have an embolic episode obstructing the superior mesenteric artery and lead to acute mesenteric ischemia. I am in my clinic now. So here is the role of full body ultrasound to get an idea what's going on before advance your investigations. Because with whole body ultrasound, you can get a very important information in a couple of minutes. And this is very important in your clinic, in your emergency room, and in ICU. First, There is really an ascites and free fluid in the abdomen. This is the pelvic free fluids. But as you see, there is jet black, no equus insides, no fibrines insides, no equus. It's clean ascites. And this is really against peritonitis as a cause of spontaneous bacterial peritonitis for our patient. This is against peritonitis, and it's also go against rupture viscous and free fluids, because in this situation you will expect to see a turbid fluids or fibrines strand inside the fluids. Okay. Intestine is very important. Intestine is very important here, because if I have acute mesenteric ischemia, I will expect to see a very thick wall, intestinal wall, and I will expect to see ileus and no peristalsis, and this is very important. Let us see the intestine of our patient. You see, this is the loop of small intestine of our patient. This is the lumen, and this is the wall of the small intestine, as you see. The diameter of the intestine here on the scale, it's almost 1.5 centimeters, so it's not dilated, and the wall has a striated pattern and no edema and no air inside the wall here. This is very good news. If I see the wall here is not thickened and the diameter of the intestine is not increased, it's very good news, and preserved striation, preserved gut stump here, gut stump here, which is a striated hypoechoic, hyperechoic. It's very important, our patient. You see? And when I start compression, it's compressible. It's compressible. You see, the intestine is compressible, and this is very good news. So I have compressible intestine with no increase in diameter on the scale here, and no increase in the wall thickness, and no and preserved the gut sump or striation here. That means this gut is good, is doing well in our patient. And this go against mesenteric ischemia really. Good. Okay. This is another loops, you see. There is good peristalsis here, good peristalsis, and free fluids in between, but good peristalsis here, but against acute mesenteric ischemia. This is another view, good peristalsis here, good peristalsis, and you see here the loop of intestine and the free fluids in between. And when I compress, it is compressible. It is compressible. Yani gut compressible. You can compress all the gut. Compress all the gut here. It's compressible, and diameter is not dilated, and good wall. Okay, very good. Liver really is markedly increased in size, 21 right loop, and the portal vein is dilated, but very good flow, anti-grade flow. It's not retrograde flow against portal hypertension, and no signs of cirrhosis really. Smooth liver here, but it's cardiac element, congested liver. But in the bladder here, you see the wall of the gallbladder is edematous and thickened. Here in this reaching to, in some area, it is 8 millimeter. More than 3 millimeter is too much thickened. So gallbladder here is markedly thickened, and there is hyperechoic mesentery all around here, denoting inflammation. And really in this patient, when I press on the my probe is here, when I press in the gallbladder, there was a severe pain, which is the sonographic Murphy signs. Sonographic Murphy signs with edematous thickening wall and no stone seen. This is going with a calcular cholecystitis in this patient, and this is very important. With this hyperechoic area all around, denoting inflammation, because this is edematous mesentery. Kidney, both kidney are normal, but there is cyst here in the right one. There is small cyst and one stone, not explain anything. But why oliguria despite this normal kidney? This is the rule of physiology here. When I put the pulsed wave Doppler here in the renal vessels, inside the renal vessel in the kidney here, I find this is the systolic flow and this is the systolic flow. You see the systolic flow is very low compared to systolic flow, and the RI, resistivity index, which is the systolic flow minus the systolic flow velocity over systolic flow velocity, it is 0.71. It is more than 0.7. That means there is vasoconstriction in this kidney, and this leads to low diastolic flow compared to systolic flow. And you see the venous flow, it's not continuous flow, it's interrupted flow, denoting congested kidney. So this kidney are normal, both kidney almost normal, despite this one stone and cyst, but the physiology is abnormal. There is vasoconstriction due to the choke, and there is congestion. And this is the cause of the oliguria in our patient. So this happened over a couple of minutes, but you collect by whole body ultrasound a very important information in very short time to send the patient this patient طبعا I sent him to ICU, but you see it is the rule of whole body ultrasound to discover all the causes of shock in our patient, which is the septic element due to acute cholecystitis and the cardiogenic element due to ischemic heart disease. And this is a case of mixed septic and cardiogenic shock. Thank you for watching. See you in another point of care ultrasound in clinic. Bye-bye.